Good evening, everyone. We've got a big group here tonight. Thanks everyone for joining in. We're just coming on the hour. We've also got a lot of people coming in. Katie says hello.
Disconnected.
So let's just get a little sound check. Can everyone hear us? Can everyone see us? Peter, you're muted. I'll unmute you there. Cool. I got a thumbs up. Hello. Yep. Hear and see. Thank you, Tiana. So this also says Finnegan. Great. Where are we at now? 69 people. All right, guys. So welcome to this presentation tonight. Thank you again for attending. It's a very exciting time in the psychedelic space. Just a little show of hands. For whom here is it the first Mind Medicine webinar that you're on? Oh, lots of hands there. Cool. Very exciting. Okay. Yes. Very exciting. First. Great. Well, so on that note, then it's probably worth doing a little bit of introduction, who are Mind Medicine and Mind Medicine Institute and what is it we stand for. So who best to answer that than we've got the co-founder of Mind Medicine Australia here, Peter Hunt. So Peter, you want to tell everyone a little bit about who are Mind Medicine Australia and what's your mission and what's this all about?
Yeah, and then I might pass to Nigel or Trail to talk about Mind Medicine Institute. But basically, we're a charity that was set up 3 years ago. We were set up with a specific reason to introduce or play a key role in introducing psychedelic-assisted therapies into our medical system. The reason we're doing that is because we've recognised that the current treatments paradigm that we have doesn't work with a large number of people. So there's a need to broaden the treatment paradigm so that our wonderful clinicians have got more tools to work with patients to help patients get well. And as many of you will know, psychedelic-assisted therapies have been showing remarkable effectiveness and safety in overseas trials. We're primarily focused on psilocybin for depression and MDMA-assisted therapy for PTSD, simply because they're the most advanced in terms of trial data. The ambition of Mind Medicine is really to do the following: to make these an integral part of our medical system so that clinicians can access them for patients where they and the patient believe it's appropriate. In other words, we have no interest in getting in the way, nor should we get in the way of the clinician-patient relationship. Secondly, we want these therapies to be affordable to all Australians. And thirdly, we want these therapies to be available to Australians wherever they live in Australia. In other words, whether they live in cities, country towns, or remote areas. As I say, we want to broaden the treatment paradigm because the current mental health statistics are really horrible. And we want to see many more people leave the sector in remission rather than stay in the sector suffering from mental illness. Nigel or Trell, do you want to talk about Mind Medicine Institute?
Sure. We can both have a go at it, I think, Trial.
Sure.
Yeah.
Do you want to go first? Or?
Yeah, sure. So Mind Medicine Institute, we've been around for about 14 months, and Peter and Tanya invited Trail and I to come in and help form and deliver the certificate of psychedelic assisted therapy. Our mission is really about how to hold this medicine work in a particular therapeutic stance. Psychotherapies and particularly psychopharmacology to date has all been focused on the reduction of symptoms, the containment, the creation of safety, keeping people alive, all good stuff that is obviously very necessary. But it's also had the effect of often keeping people entrapped in misery. So psychedelic medicine really creates an opportunity for growth, expansion, and deep healing. But in order for us to do that ethically, systematically, and do that well, we have to have really well-governed, really well-understood therapeutic guidelines, ethical standards, and very good interdisciplinary communication in order for us to do this as a really powerful and transformative task. And so Mind Medicine Institute is really, our mission is to really develop the therapy well and to support the development of our understanding of what psychedelic medicine really needs to look like to really be at its most effective.
Yeah, thanks, Nigel. I think that's a great synopsis of the focus of our work. And I guess what I would add is that, our mission is to explore and develop and teach the best approaches to fostering mental health and wellness as concepts. And we have a series of kind of key focuses that allow us to do that. We want to engage leading edge international thinkers and faculty. We want to commit to working within strong ethical and legal frameworks, which is obviously very important within the psychedelic space. We look at drawing in best evidence, but we're trying to also do that within a multidisciplinary perspective, which, engages with things as diverse as Indigenous knowledge and neuroscience. Like we're trying to bridge those spaces. And we're looking to the new horizons for continuous improvement on clinical practice and trying to develop new and interesting ways of bettering our process. So that's the focus of the Institute.
If I could just round that, Gavin, if our ambition, which it is to see these therapies part of our medical system, you've got to have trained therapists who understand how to deal with people who are going through altered states as a way of exploring in their own minds the causes of their trauma or other mental illness. And what Nigel and Trail have developed is a certificate in psychedelic assisted therapies for clinicians. And I'm very proud to say that Professor David Nutt, who many of you may know, is head of neuropsychopharmacology at Imperial College London and one of the leaders in this field globally, recently described the course developed by Nigel and Trail as, in quotes, the best of its kind in the world. So we really are focused on high standards for our clinicians so that this can become an integral part of our medical system safely and get great results for patients who are really suffering from key classes of mental illness.
Yeah, very exciting stuff, guys. And so, just for a little context, I started working with mind medicine in a marketing capacity probably about a year ago. And I've been, really felt very proud and fortunate to help this organization because it really is one of the leading organizations in the world at really pushing the frontiers of psychology and psychedelics and creating this new paradigm. So, on that note then, as you've signed up for this presentation, you kind of know that it's going to be a structured conversation about really the state of psychedelics, where we're at, and how you can be part of this very historic moment in time where we have really now the opportunity after 50 years to actually shift things and make a difference. And we'll get to talking to that in a minute. But all right, Peter, so maybe you can tell us a little bit about the state of the mental health system at the moment and what really prompted you some 3-4 years ago now to look at bringing innovation to the mental health sector.
All right, well, I'm not a clinician, so people need to understand that. I'm somebody with my wife who came into this sector 3 years ago. And when you look at the sector, and it's really the elephant in the room. Whilst we have incredible clinicians who really care, and whilst we have lots of resources going into the mental health sector, unfortunately, the treatments that we have don't get a large number of people into remission. So if you think about these statistics, if you've got depression, on the basis of research, you've probably got a 35% type chance of going into remission. If you've got post-traumatic stress disorder, it's probably only about 10%. Yes, current treatments may give you a positive response, but a positive response doesn't get you well, doesn't mean you get well. And the pharmaceuticals, particularly SSRIs, can have nasty side effects. So we came into this system and looked at a system where there's really been very little treatment innovation in the last 50 years. The science of the pharmaceuticals is 50 years old. And that lack of treatment innovation means that the mental health outcomes that we're getting today are really no better than the mental health outcomes that we had 50 years ago. And over that period, mental illness has increased dramatically. And we're now in a situation where 1 in 8 Australians pre-COVID were on SSRIs, 1 in 30 younger people. But hear this statistic, 1 in 4 older people pre-COVID were on SSRIs. And yet the mental health statistics seem to keep getting worse. So in that environment, we were really keen to see innovation. And we looked overseas and we saw these psychedelic assisted therapies producing outstanding results in clinical trials in terms of remission rates. but also showing high safety levels when they're used properly in medically controlled environments. And we want Australia to be a leader in this, not somebody who's slow off the mark, because we think we've got to a stage now where all the evidence shows that properly managed, these therapies can not only be used safely in medically controlled environments, but they can produce what are truly outstanding results in terms of getting people into remission, and therefore outside of the mental health system in key classes of mental illness like depression and post-traumatic stress disorder, but also potentially, body disorders, like anorexia. And they're also being trialed now for OCD and a range of other classes of mental illness. Trail or Nigel, would you like to expand on that as clinicians?
Yeah.
Sure.
Which one?
Go for it, Trail.
Well, I guess, as people involved in this work, one of the things that I often come up, get asked about is my views on these medicines and substances. And, my stance on these is that I'm not evangelical about them personally. What I'm really interested in is making the world a better place and looking at the science and looking at the literature and looking at the benefits that it has, experientially. And I think we're in a situation now where it's pretty clear that the benefits of these medicines outweigh any of the risks or concerns about them. And what we're really dealing with is a lag in people's ability to understand that and see that and develop a kind of open mind to their application and utility. And so we're really interested in obviously bringing these things forward. But one of the key focuses that Nigel and myself kind of want to bring to this is trying to get some of the attention off the substances themselves and focus more on the therapeutic quality and the therapeutic skills that are required. Because the simple fact is that it's not just the medicines themselves, they form part of a more complex event, which is the setting, the therapeutic skills, the therapeutic relationship. There's a whole series of factors which, with good clinical application, can transform the experiences that people have under these substances into incredibly healing events. And that is really at the forefront of my intention and Nigel's intention and what we're trying to do here as a group and as a team. And I think that's really important to say up front.
I should just add, if I may, Gavin, there's a great question from Kayla in the chat, where she says, I'm quite confused. CPAT, which is the Certificate of Psychedelic Assisted Therapies, which both Nigel and Trail lead, was run by not-for-profit My Medicine Australia when I signed up, and none of us heard about the for-profit MMI until January this year. If I can just explain that, My Medicine Institute is part of the My Medicine Australia group, and bear in mind, we're a not-for-profit. The reason we've put our therapist training activities into My Medicine Institute is we recognise that the training activities need to be run by clinicians. And My Medicine Institute is a completely run clinician organisation focused on educational activities, whereas My Medicine Australia is really focused on building awareness, outreach into the university sector, advocacy for change, and all the practical things that need to take place to make these therapies part of our mental health system, such as securing supplies of medical grade MDMA and psilocybin, rescheduling the medicines, which we'll come on to shortly, clinical rollouts, looking at ways to reduce the costs of these treatments, all of the practical things that go into making these part of our medical system, but not the clinical part. That's run by My Medicine Institute, but as part of the Mind Medicine Australia group. I hope that's a bit clearer. But if I've confused anybody, please please raise your hand and we can expand upon that. It's just recognising that clinical training should be run by a clinically run company, manned by clinicians, rather than people like Tanya and myself who aren't clinicians, but are very strong advocates for this change.
Yeah. Awesome. All right. Well, yeah, good to clear that up and get some intro and some context as what is we're trying to achieve. And so, yeah, I guess the next point we sort of want to talk about, obviously, yeah, there's these challenges in the mental health system, and we've got a sort of ways of, trying to bring this innovation here. Maybe you guys can speak to some of the changing public and professional, attitudes towards psychedelics. I mean, sort of 5 years ago, these were maybe something that people weren't talking about as much. I can certainly speak to some of the public attitudes. We ran a poll earlier this year to poll Australians about how they felt about psychedelic therapies, and the results were actually quite fascinating. I'll share my screen if you're so inclined, and I can share people what the results were. So basically on this poll, we asked people, if clinical trials showed psychedelic assisted therapy is effective in treating mental illness, to what extent would you support or oppose federal government regulating the use of psychedelics in medically controlled environments? And as you can see, we had 64% of people saying they strongly support or somewhat support, and 28% of people neither supporting nor opposing. So you can see that, at this point, over 90% of people are sort of open to these substances, which is quite exciting. And as Peter was pointing out earlier today, even somewhat opposed means that people are quite open to these treatments if they can be, demonstrated that they have clinical utility, with only 3% of people strongly opposing them. So there really is a shifting tide, a changing tide, if you will, in the acceptance of these substances. Would you guys like to speak to that and maybe how it's you've seen this as well in your experience as clinicians?
Yeah, so I've been in this area for 35 years. I met Stan Groff 30 years ago, and there's never in my life did I think that we would see a renaissance that we're seeing in the last 5 years or so. And having worked with a lot of people that had been part of that first genesis, the promise and hope that was being generated clinically back in those days, to have that kind of removed from our research and clinical kind of capacity was heartbreaking for a lot of people. And so just watching the very, very kind of slow and steady work that people like Charles Grob and Michael Midhofer have been doing over decades now, really building up a credible base of research. It's just fascinating to see how quickly it started to now really kind of take off. And so, as Trail was saying before, I mean, we've got to be very, very careful that we don't see this as a panacea, but what we do see it as is an opportunity to really rethink how we approach this work, because it is exploding. There are more and more trials starting across the world and across Australia, many of which Mind Medicine Australia has been instrumental in and deeply involved with. And it's a growing tide. So it's a growing tide of real promise, held at the moment within a trial environment. And one of the points that Trail was making before around the introduction of SSRIs back in the late 80s, early 90s, SSRIs came in as a trial-based medicine that was linked to therapy. SSRIs were never intended to be used purely as a medicine themselves, independent of therapy. And if you read the fine print on any of the boxes of SSRIs, you'll see the recommendation is that they're used with what. Is that all right? Sound okay?
Yeah, you're clear now, Nigel. I don't know what the interference was.
Yeah, I wasn't getting it this end. So, what did we miss?
Well, I heard the whole thing. So
I heard the whole thing as well. Yeah.
So yeah, SSRIs really have been a bit of a tragic kind of loss of the relationship between therapy and medication. So we're really keen to see not just this trial environment work, and this is the kind of conversations that we're having a lot with our students, is once it moves out of the trial phase, and once you move out of having very selective patient groups entering into treatment, when it moves out into more of the therapeutic space and more complex presentation, this is where we really need to be asking questions right now and preparing ourselves for what really good therapeutic use of these medicines needs to look like.
Yep.
And we started that process back in the 60s, and you know, we certainly didn't complete it. So that's our challenge ahead of us moving forward now. What does a psychotherapy that really enhances medicine look like?
If I can perhaps just make a couple of points, Gavin.
Yeah, for sure.
We are starting to see a tipping point in Australia. You know, social change is not a linear thing. What tends to happen is that nothing seems to be happening for a long time, but underneath the surface, there's pressure mounting. And you can see the results in those polling numbers, where actually the overwhelming number of Australians polled were either in favour or were prepared to be convinced. And that's a great basis for introducing a paradigm shift in medical treatments through the regulatory environments. That's very positive. The second thing that's pushing this tipping point and is leading to those poll results is the data we're getting in from overseas, the success of these overseas trials. But the third point I wanted to stress, and I think it's why people are so amenable to considering these therapies, is that, you know, you'd have to have your head completely in the sand in Australia to believe that our mental health system was actually was actually generating remissions in the vast number of people who came into the sector. I mean, all of us have I'm sure had the experience of either we've suffered mental illness ourselves, we've had family members who've suffered mental illness, or we've got close friends. We've seen them go into the mental health system, and you know, they may be going into therapy year after year. They may be taking SSRIs year after year, and they're just not getting into remission. They're just not getting well. And I think when you add those three things together, you know, these great overseas trial results, the fact that you'd have to be, frankly, pretty disconnected not to realize that the mental health system isn't delivering in the way that it should be. And the fact that treatments are fundamentally the cause of that unless we have better treatments, you can put no end of resources into the sector, but you won't change the number of people getting well markedly unless you have treatments that get people well.
Yeah, well, we brought up some really interesting points here, and I know that on this call there's a mixture of, you know, therapists and patients as well. And so what I'm guessing I'm hearing from you guys is that there's two elements to this. One is you know, the reintroduction of these substances which are demonstrating significant clinical potential and results in some cases, and also, you know, as you were speaking to, Nigel, like a shift in the overall paradigm about you know, of the treatment of mental health as a whole. Is that a fair sort of synopsis of this, of that part of what you're saying?
Yeah, definitely. It's how we've been focusing on mental health as a mental illness for far too long, and we have not taken the opportunities for growth, development, and transcendence seriously enough as therapists. And so, you know, that's really what we're being asked to really look at, you know, more of the positive psychology, more of the transformative, most of the post-traumatic growth, these kind of concepts. We're really kind of looking towards what constitutes real healing.
Yeah, and maybe Trail, if you're there, you can speak to some of the differences and like at the mechanical level for people who, you know, maybe don't know, like what is actually functionally different between a psychedelic assisted therapy and, you know, an SSRI when it comes to sort of, you know, looking at someone's mental health.
Well, I guess the key message is what Nigel's just said, which is the conventional medicines are essentially trying to maintain or subdue symptoms, but that's not the path of a psychedelic treatment. The path of a psychedelic treatment is to literally try and find a growth-orientated solution. So, you know, in simple terms, and this is grossly simplified, of course, but one is suppressive and one is growth-orientated. And it's not to say that there is not great value in, you know, all the work that's been done and
There aren't times and places for conventional psychiatric approaches, but what we're suggesting is that there's also a place for something which looks at human growth and human potentiation as something which is actually really important in mental health. And in our society, unfortunately, what we see is this role of, what Nigel referred to as transcendence before has been essentially eradicated from, the modern Western lexicon. And nonetheless, it plays an important part in human psychological life. And, we can't return to a state of, religiosity or any of those things. We can't roll back the tide on those functions of society, but we are capable of providing a grounded, supported clinical experience which helps people move past and transcend some of the terrible experiences that they're wrestling with. And, that's the essence of not just the medicines, but the treatment themselves. And I think that that's one of the things that we would like to really kind of highlight. This is what's really important for us, is that it's the total package of treatment that allows that to occur.
Mm-hmm.
Because if you think about an SRI, you get given it, you go home, and that's it. And as Nigel's fond of saying, when they were originally introduced, they were meant to be used in conjunction with psychotherapy as a support for psychotherapy, and now they've become a treatment unto themselves, where the medicine's just doing its action, regardless of the experience. And that's not true of psychedelic medicines. A psychedelic medicine is about an experience. It's not just about some bioregulatory effect. It is actually about the experience that is generated. It's the experience that changes people, and great therapists are able to support, and in a lot of the work that Nigel and I do, focus on ways of converting or stabilizing the view that's achieved in those experiences longitudinally, and that's very important.
Well, so then what are the rewards for, and because that's the title of this presentation, risk, rewards, and a roadmap for hope. And I think that's what we're all kind of looking for. And so, for the therapists that are willing to embrace this, and even for their patients, like what are the key sort of benefits that they can sort of, reasonably expect from embracing this way of looking at things and psychedelics generally?
One of the, oh, sorry, Carl.
I was going to say, if the trial results are anything to go by, what we can expect is an increase in efficacy in treatment for depressive and PTSD resistant patients at a minimum. Right, we can expect that, and not at a, and not just marginally, at a fairly large level. That said, it's important to recognise in, for example, in MAPS trials, there's still 20% of people who don't get better. And it's important that we hold a balanced perspective on those things and name those things for what they are. But, as clinicians, what we can expect is to increase the efficacy of our treatment, which is to help people, which is why we do the work we do, to try and help people live better lives. Nigel, you were going to say something, man?
Yeah, and I think you've just covered it, Trail. I mean, we're really, it's about giving people something that they can hold, a new set of skills. We know this at a neurological basis. We know that there's kind of structures in the brain that become solidified and rigidified in relation to the interaction between our biological inheritance and our experiences. And it's those rigidities in our brain that cause rigidities in our consciousness, that cause what we would describe as suffering. And so what we're doing with these sort of these interventions is helping to reprogram. We're boot-starting that kind of biologically organised structure of brain, and helping therefore restructure the way that people are thinking and experiencing themselves. I mean, it's a very different approach to suppressing symptoms.
And Nigel, it's important to recognise that this doesn't come from nowhere either. I mean, obviously, the previous iterations of psychedelic-assisted therapy are important, but also the transpersonal psychological movement, the potentials movement, the Easternization movement, all these areas, positive psychology in more recent years, led by Seligman. These are all attempts and recognitions that there needs to be a more totalizing account of the person. I think about the first ever Congress of Transpersonal Psychology, and the purpose was to create a total account of human experience.
Yeah.
That's still what we're wrestling with, really, is it?
Yeah. And Carl Rogers was described as the greatest psychologist next to Sigmund Freud in the 20th century. Yet his works almost disappeared from the landscape in recent times. And that whole tradition of developmental, experiential, motivational kind of growth that Rogers forwarded, which was taken up by Maslow, which then led to transpersonal psychology as an attempt to integrate East and Western approaches to the theory of mind. That's what that was all about, and just trying to understand, how do we grow, how do we develop, how do we transcend our suffering, how do we make meaning from it?
Yeah.
Gavin, there's a couple of technical questions from clinicians in the chat, which might be just worth Nigel and Trail briefly commenting on. The first one is contraindications, and the second one is there's a question from Stella about, is there any evidence for using psychedelic-assisted treatments to treat complex PTSD, stroke developmental PTSD?
Yeah, so if I speak to that one, obviously the MAPS trials, were involved in treating PTSD. Much of what you're seeing there is kind of complex PTSD. I think the average diagnostic period for participants in the MAPS trial, I think, was 14 years, but I think it was even as high as 22 years, I think, was the diagnostic period. And obviously the success rates in the MAPS trials are quite extraordinary. You're looking at, at least initially, around 35% remission, 68%, I think, escaping diagnostic, and 89% with significant quality of life improvement. But what's interesting with the MAPS trials is those numbers, if the other phase trials are anything to go by, increase as time goes on. And, they're expecting those results to, be, somewhere between 65 and 80% remission. And so, it's pretty extraordinary to look at that and to recognize the value in it.
It's important to note, though, from those MAPS trials, we had something like 1,000 people applied for phase 3, and that field was reduced to 100 participants. So there are a number of people that were deemed unsuitable, which kind of picks up the first question: who are these unsuitable for? And suitability for trial is very different to suitability for therapy. Yeah. Suitability for trials generally means that you are not presenting with a complex, multi-dimensional diagnosis, such as PTSD and an addiction disorder, or PTSD and depressive disorder, etc. So we do need to kind of look at complexity a lot more. And the people that really don't, that are contraindicated due to degree trial, I think are where we don't have sufficient organisation of mind, where we have people with psychotic spectrum disorder, or people who don't have adequate reflective functioning, people who are perhaps severely on an autistic spectrum, or have intellectual capacity issues.
Yeah, exactly. And I think that the other obviously exclusion criteria are purely medical, which Nigel didn't mention. So things like certain cardiac conditions, any of those kind of things can be grounds for exclusion. But the space around the psychological exclusion criteria continues to change and grow. It wasn't that long ago they were saying that people with personality disorders would be excluded, and then lo and behold, people are exploring the space and looking at developing trials to explore that. So currently, as Nigel said, really it's the reflective function that's probably the key indicator, but to what degree and in what nature, remains to be seen over time.
The issue with trials is, because someone else asked a question about comorbidities, but that's always the issue around trials, is you're trying to measure pre-post a singular problem. So when people are presenting with multiple problems, you then have complexity in the research. So that's why we make our point about what a therapy needs to look like, rather than simply what does a trial need to look like.
Nigel, do you want to just maybe add to that around, there's a quality then in some of the trials where they actually try and reduce the therapeutic component in order to?
Yeah. I mean, and this is really an interesting area that we talk about a lot, because, you know, when we've designed a suggested treatment structure, we've drawn from the structure of the trials, but some of the trials are trying to exclude therapies or reduce therapies to the point where they are simply looking at the medical impact and then the biological changes associated with the induction of the medicines. And these are kind of important methodological processes for science, but we don't want to kind of get that confused with what treatment needs to look like once the TGA has rescheduled and once we're out in a kind of a broader prescription base. You know, we need to start thinking a bit more broadly about what we're affecting and how we're affecting it.
All right. Yeah, those questions certainly brought up some very, very, fascinating stuff. I mean, it really speaks to the nature of science and some of the challenges in science as a whole. But Peter, was there anything you wanted to sort of add to that before we kind of move forward?
No, I think it's been a good discussion, and it's good to sort of get into the clinical aspects in a bit more detail.
Yeah, absolutely. So I guess to that end, obviously for the people who are here for the first time and don't know exactly where, Australian Mind Medicine Institute stand on this, like what exactly are we proposing regarding the introduction of psychedelics? And maybe Peter, you can speak to, the specific submission that you've just made recently to the TGA and what exactly it is that you're proposing.
Yeah, well, to start off by contextualizing it, you'll all understand the difference between registered and unregistered medicine. Registered medicine goes through the trial process, gets registered on the ART register, and then it's available for doctors to use without going back each time to the regulator for permission. Unregistered medicine is also available, but it has to be accessed by either case-by-case approvals from the regulator, or alternatively a doctor or a medical practitioner becoming a person who's prescribed by the regulator to issue or prescribe that form of medicine for a particular class of illness. It's going to be some years before MDMA and psilocybin are registered medicines in Australia. So what we're focused on is access through the medical system to these substances as unregistered medicines. Now, currently they're in Schedule 9 of what's called the poison standard, which is the standard by which our regulator, the TGA, and regulators around Australia at the state territory government level schedule substances in terms of risk, essentially risk. Because of the war on drugs, which Nigel briefly referred to, we're in a situation today where the medical use of psilocybin and MDMA is in Schedule 9, which is labelled prohibited substance. Now, again, labels can confuse because in the case of psilocybin and MDMA, we've had about 30 approvals given to psychiatrists on a case-by-case basis by the TGA under what's referred to as a special access scheme. So at the federal level, they have been giving approvals for its use. The problem is we live in a state federal system or a federated system, and control over medicines is shared between the Commonwealth and states and territories. And in every state and territory of Australia, other than Victoria, there are no permit access gateways for practitioners, medical practitioners, to get permission to use these medicines as part of therapy. So, we're in this dysfunctional position where you can get approval at the Commonwealth level as a psychiatrist, but if you then try to implement the treatment at the state level, you actually fall foul of the recreational drug provisions, which is absurd given the efficacy that we're seeing with these therapies. So what we're endeavouring to do is move the scheduling of these substances from Schedule 9 to Schedule 8. And if we can get them into Schedule 8, then there are permit processes available in each state and territory of Australia. In other words, on a case-by-case basis, a psychiatrist will be able to apply to the TGA for approval and to his or her local state or territory health department for approval. And with both approvals, they'll then be able to provide the therapy. Now, that's obviously a very lumpy way of doing this, But if you think about medicinal cannabis actually requires approval at both the federal and state levels. And yet, I think we've now seen over 100,000 approvals being given in the last few years, and it's really starting to accelerate. So our hope is that if these medicines can be rescheduled to Schedule 8 on the restrictive basis that we're proposing, what we'll see is a gradual take-up of these treatments by psychiatrists and their patients. We'll see success in clinical practice, which is very different, as Nigel alluded to, than trials. And as it's shown to be more and more successful, more and more psychiatrists and patients adopting these treatments, and more patients getting well and out of the mental health system. So that's what we're trying to do. And we're in an application process at the moment to do just that.
Amazing. Yeah, Nigel and Trell, did you want to add anything to that? Or?
Yeah. Very
Perfect.
clear.
Very clear. Peter said that many times. So, all right, guys. Well, look. So, we talked about some of the rewards and some of the upsides of this. So, what are some of the key risks that that exist in these therapies, and how have we sort of thought through managing these risks, mitigating them, and really being sensible about this? Who wants to take the lead on that one?
Well, I'll jump in first if you like, and
Sure.
let's just begin by saying, part of the title of this conversation, involves hope, and hope's always on a tightrope. It's always a fine balance to keep hope alive in some ways. And this work is a good example of that, is that there are people who wish to see this work not put forward in a sound kind of clinical framework, rather they're fearful or doubtful or whatever. And, to my mind, some of the greatest risks are actually what happens in the in-between space between clinical certification and acceptance, and people using these substances and adopting this therapy in, what are often referred to as underground ways. I think, to me, that is probably some of the biggest danger. Then that doesn't mean to say there's not many people out there who are working in that setting who are probably terrific. But given that the potentials for abuse, the potentials for vulnerability in the patient populations, I feel like that's one of the great risks that we run. Nigel, what do you think about that?
Yeah, I agree with you there, Trell. Another thought sort of popped into my mind, that was an old an elderly patient I had years ago who had been alive and a young adult in the era of legal LSD. He went into he was checked into a private hospital, largely because he had quite severe anxiety. Checked into a private hospital, put into a private ward, so a 1-bed ward. Psychiatrist gave him the LSD and then popped the cure on the bedside table next to him, and then left the room. He started to feel the onset of the LSD, went into an amplification of his panic, and then took the cure. The danger of at the exact opposite end of the scale that you're talking about there, Trial, in the underground use, is in the unembedded medicalization of it, where we have an alternate sort of potential problem, where we don't understand the action on the mind, the action on the psyche, the action on human relationship, the action on the term that comes up over and over for us with our students in the work we're doing is connection. People learn through these medicines to connect with themselves differently, to connect with each other differently, to connect with their history differently, to connect with their ecology differently. And it's this sort of kind of idea of connection that really seems to resonate for a lot of people when we're working in this area. So at one end, we've got uncontrolled use, which people do benefit from it. There are people that are having great experiences out there in underground environments. We don't want to suggest that's not the case, but there's no containment, control, or regulation of it, so there's no safety there, and that's the sort of problem that regulators look at.
Yeah.
And we've got the excess medicalisation and commercialisation of this at the other end of the spectrum, because it's a lot cheaper to just deliver medicine in a hospital room than it is to sit with two therapists over a period of time, sitting with someone in a nicely appointed room where the setting is really formed in a warm and inviting kind of system, and then multiple sessions then to help integrate that experience.
Yeah, I think that's well put, Nigel, and it kind of, I guess, speaks to my point about it being a tightrope, that there's either side of this kind of space has its dangers and its risks, and we're really trying to tread that line, and tread a path and keep this work open. I guess one of the other dangers, I think, for me, and given some of my interest in ethnomedicine and things like that, which builds on Nigel's point, would be the eradication of Indigenous knowledge in this space. I mean, I think I'm not an advocate for the full-scale adoption of Indigenous practices around this. I have serious concerns about that in terms of cultural appropriation and other such notions. But I do think there's a great deal to learn from Indigenous ways of knowing. I think there's a great lineage of knowledge that happened. It's actually in the Western psychotherapeutic tradition that began with Groff and it's been carried forward in those traditions. And I think that material has to be held on to and engaged with. And I do see sometimes an attempt to not just go down a psychiatric biologicalism, but also in psychology sometimes just the desire to adopt an existing clinical model as an explanatory power over the top of the deeper knowledge and skills that have been developed longitudinally. So I think that that's probably a more subtle point, but nonetheless, I think that's an important one that we need to watch for.
Peter?
By the way, there's a comment just in the chat, which is a good one, and that is basically if these therapies become legal in the short term, on the limited basis that I've talked about, do we have enough clinicians who have been properly trained? And that's exactly what Mind Medicine Institute and Nigel and Trail are trying to do. I think last year we trained just under 100 psychiatrists, psychologists, psychotherapists, and so forth. This year it's going to be just shy of 200. In the early days, we're not going to see an explosion of these therapies because it's going to be cautious, but obviously there'll be an acceleration as we get the expected good results. And what we've got to make sure is that, we increase the level of training for clinicians so that we have enough clinicians to do these therapies. And we're very focused on that.
What we're doing as part of Mind Medicine Institute is establishing a community of clinicians who can also share their wisdom, share their knowledge, and kind of understand the importance of this work in anticipation of its availability in the interim. There are a lot of people out there that get themselves into strife using these medicines in an unsupervised fashion. So if we've got clinicians that are sensitized to some of those problems, then we've got good people that can do integration work so that people don't get lost, for instance, in the psychiatric system when what they're having is an unintegrated reaction to a psychedelic or an empathogenic, which unfortunately is not an uncommon presentation.
The other thing I just highlight, Gavin, if I may, that the question is being asked, well, what about courses for non-clinicians?
Yeah.
And I mean, there is a course again run by Nigel and Trail called Fundamentals of Psychedelic Assisted Therapies, which I think is a 4-week online course. And again, it's targeted at primarily at non-clinicians, although we find that quite a few clinicians join the group and then actually go on to do the full CPAT course.
Mm-hmm. Yeah, absolutely. We can certainly speak about those resources. I guess, on the concept of risk, I suppose the thing we're finding interesting is that, there is also a risk in doing nothing, right? So, obviously, as Mind Medicine and as the guys have sort of, made clear, we're not sort of naive or, blurry-eyed as to what it means to reintroduce psychedelics back into the medical paradigm. But, I suppose the question is that, if we balance this risk against the risk of doing nothing and simply letting things go as they are, I mean, Peter, Nigel, and Trail, you guys are obviously experts in the field. Like, what happens to the state of mental health in Australia? What happens if we just ignore it and just hope that it's magically gonna change?
Well, it won't change. I mean, that's the problem. It's Unfortunately, governments tend to focus on process. So when you talk about problems in mental health, and there's been a lot of publicity about the worsening mental health crisis, the tendency of governments is to say, well, the way we sort this out is to have yet another Royal Commission to write another report and to devise ways of increasing resourcing in the sector. Now, I'm a great believer in increasing resourcing in the sector, but I think the theme that I want to convey is that putting more resources in the sector is great, but if you haven't got the treatments that get a large number of people well, the resources alone aren't going to solve the problem. We've got to have innovation. And when you look at these therapies, as I say, they're showing remarkable remission rates, remarkable response rates, and they've been shown to be safe in medically controlled environments and non-addictive. And I've just got to say, if I may, on the addiction issue, they've done tests with rats, and they've given, you know, those tests where a rat has to put out its claw and pull down a bar, and the bar releases a tablet. They've done tests with rats and with cocaine, and the rats keep coming back to get more and more tablets. They do the same tests with psilocybin, and the rat doesn't come back. And I think it's just indicative of the fact that psilocybin in and of itself is not addictive when you use it in this way.
So, Peter, I think it's important for us to make the distinction between biological addiction and, I guess, you know, behavioural addiction.
Yeah,
and
right.
that we do have, that, you know, we don't want to downplay the fact that, you know, attachment states is a powerful experience, and it's something which happens frequently. And Nigel, do you want to maybe just talk to this just a moment, this idea of a, you know, attachment to states and how that plays out as a kind of behavioural addiction sometimes?
Yeah, I mean, what happens when we have a positive or peak experience under psychedelics is where our brain gets flooded with a whole bunch of neurotransmitters. We have an experience of something different. We perceive the world in a different way. Emotionally, we feel different. So there's this kind of remarkable kind of quality that we can experience with the medicine, and that becomes really intoxicating. Because when people come down and they're not integrating that experience into an understanding of themselves and their embeddedness in the world that they occupy, if they're not really understanding the value and the fact that the medicine is accessing something that is inherent to them rather than creating something that is external to them, what then happens is they go looking for the medicine again. They go looking for the experience again. And so this is, you know, really common in unfortunately. It's not, as Trail says, it's not a biochemical addiction, but people want the state. And part of that is because they haven't recognized that what they're experiencing is part of their own personal constitution. Those positive experiences need to be embedded and integrated in a broader sense of who they are and what they experience and what they perceive, than to go looking for the medicine to provide that over and over.
And Nigel, this is why the therapeutic component is so important, isn't it? Because
totally.
that, you know, I think we are one voice when we say that the most important dimension of psychedelic assisted therapy is the preparation and integration. And in particular, the integration phase is essential. And without proper integration, people can get caught up in these problematic states. But with good integration skills and good treatment at an integration level, you know, these experiences become far, far, far fewer, and we're able to kind of create much more positive experience for people.
Exactly, Trell. And without that systematic integration, then opportunities get lost. Even if someone doesn't have a negative experience, what happens is a really strong positive opportunity gets filed away in memory as something that isn't resourced potentially.
Yeah.
Fascinating stuff. All right. Well, we've got a few more questions, but I guess just to sort of sum it up, because it's obviously a fascinating and complex topic. You know, on balance, if we're at a place now, which we are, where we have the opportunity to, you know, increase access to psychedelic assisted therapies in sort of very restrictive sorts of situations, as Peter described. I mean, you guys as clinicians, would you on balance say that is a direction? Is that a less risky or more risky approach to take? And that's
what was the risk? Sorry, Gavin.
Well, it's we're at a situation now, where we have the the opportunity to have these medicines downscheduled to a place where they can be used more readily in the medical system. Looking at all of the risks and rewards, like on balance, as clinicians, would you say that it is better to move forward with that, or are we not there yet?
Yeah. Provided we do it with really good balanced science. And that's science that's speculative. That's science that really opens to phenomena and really starts to get very, very curious about what happens in state change, as well as doing things safely and as well as doing things ethically. We need to engage with a spirit of science that is really about the exploration of the mind. This is what one of my mentors, Stan Groff, would talk about. Psychedelics are to the mind what the telescope is for astronomy and what the microscope is for biology. I mean, it's an extraordinary opportunity if we use our knowledge, we use our philosophical, historical, scientific understandings to systematically apply them to this work. I think it's a remarkable opportunity. If we don't take that step bravely, then we'll collapse into reductionism.
Yeah, Peter, did you want to add to that?
Yeah, well, just another topic I'm just seeing on some of these questions coming through the chat. I'm finding fascinating, and there's a couple of questions or points raised about Indigenous people and what we can learn from our own Indigenous people. And somebody's suggesting that they may have used psychedelics. Other people are suggesting they didn't.
Yeah, I mean,
I'll just finish there. Go back.
Yeah.
What we hear from Indigenous people that we come in contact with is that there is a history of use of psychedelics going back into the distant past. The acacia tree, as some on this call may know, the bark of the acacia tree contains DMT, and can be smoked. So that there is psychedelics available, which may have been used. What we're trying to do what we're looking to do at Mind Medicine is bring out to Australia sometime soon one of the world's leading anthropologists, an individual called Wade Davis, who many of you may know, who's an extraordinary anthropologist and very, very empathic with Indigenous people, to team Wade up with a local Indigenous person and to really research this whole area in a proper way to see what can be learned, but in a way that's empathic to Indigenous culture. And is highly respectful of our Indigenous populations.
Awesome. Wonderful. All right. And just any other questions in there? Okay, so Tiana's asking, where can non-clinicians find information about Indigenous psychedelic use to avoid appropriation? Okay, that's probably been answered.
If I can just make a point here, Gavin, I think there's a few things to say. I mean, first of all right, so, people like Wade Davies are just incredible, and we're very lucky to have them, on the faculty and things like that. Like, it's just incredible. I recently had a meeting with Michael Winkelman, who's also one of the world's leading authorities in shamanism and shamanic healing. Last week I emailed Tyson Yunkaporta, because there's a distinction, I think, between the ways of knowing themselves and the techniques and strategies of use. And one of the things that I think is really important is to recognize that we can honor Indigenous practices by honoring their teaching, the message, without necessarily having to fully go and annex and take away and essentially culturally appropriate their individual strategies, techniques, and methods. And I think that's something that I really like to name really clearly, because otherwise we really do get into a problem of perpetuating various types of violence. And so I think, what Peter's talking about there and getting Wade to come over and do this work is, obviously one of the most qualified people in the world to do that, is to really learn, to take an attitude of learning, not an attitude of extraction.
Yeah, quite right.
And I think that's the big difference. And that's the point that, for example, in the CPAT program, that I really tried to labor over quite heavily. I've had a long history in ethnomedicine, and it's one of my enduring lifelong interests. And for me, it's very much about learning from not taking from. And that distinction, I just wanted to make that really clear, that that's what we're talking about.
Yeah, really important, very, very important. Gavin, I wonder if you want to turn to the Schedule 8 rescheduling process so that people can start focusing on what they can do to try and make these therapies available.
Yep.
Yeah.
Absolutely, Peter. Well, do you want to explain what's going on now and where we're at in that process?
Yeah, I wonder if you could put that slide on that shows the timeline.
Yep, I certainly can. Just give me 1 second.
And I might just explain that to people.
Yeah.
And while you're doing that, I mean, what people on this call may start to realize now is that at Mind Medicine, we're not interested in just talking. We actually want to see change, and to see change, we've got to take a really pivotal role in leading that change. But we can only do it if we're supported by a movement of people that's going to work with us. So with that background, we might just go on to this slide. Yeah, this is the timeline. We first put in an application to reschedule these medicines as part of psychotherapy back in July 2020. And it was a long, arduous process, but last December, the TGA refused to reschedule. And that was clearly disappointing for us, but it had a very great benefit to us. And that was that the TGA, or the delegate who acts for the TGA, had to give their reasons. And that's enabled us to go back, lodging a new application in early March, which specifically addresses the reasons given by the delegate to the TGA. So rather than having to have a scattergun approach, we've gone back in a really targeted way. It's a more restricted application. What the application basically says, and this answers a question in the chat, is that in order for these, is that we're looking at a restrictive rescheduling to Schedule 8 on the basis that these therapies will only be available if a psychiatrist who's been specifically trained in the use of these therapies prescribes the treatment, the psychiatrist to a treatment-resistant patient. The psychiatrist's patient diagnosis and treatment plan is then confirmed by 2 other psychiatrists. It's all conducted at a medically controlled, or the medicine dosing part of it is conducted at a medically controlled environment with two trained therapists in the room at all times. Now that's a pretty restrictive rescheduling because all other uses of psilocybin and MDMA would remain in Schedule 9. And some of you on the call may be saying, well, Mind Medicine, that's incredibly restrictive. Why haven't you been more liberal in your rescheduling application? And my answer to you would be, well, we can put together the ideal application, but actually, if strategically, it's not something that the regulator will be comfortable with, it'll be rejected. So we're better off starting on a highly restrictive basis, getting everyone comfortable in the system that these therapies work in practice as they translate from a trial environment to a clinical environment. And then over time, as people get more comfortable, hopefully the restrictions will start to become more liberal. In terms of the process for rescheduling both MDMA and psilocybin on that basis, we're going to go through a lengthy process. There's a public submission process now, which opened yesterday and closes on the 27th of May, which gives everyone the ability to go on to the TGA website and make a submission in relation to our applications. Now, you can find our applications that we lodged on our website under the News tab and TGA tab. But what we'll do after this call is we'll send around a note with all the links so that you have them, and also a how-to guide. That public submission period is 20 days. It's incredibly important that we get as many submissions in as possible. Then you have a meeting of what's called the Medicine Scheduling Committee in late June. And that committee has the legislative task of advising the delegate on whether or not these substances should be rescheduled. So it's a pretty important committee. Now, when you look at the committee, it's sort of interesting because whilst it's a TGA committee, eight members are appointed by the Commonwealth and they're all external appointments, so non-government people, but 9 people are appointed by the various states and territories around Australia, and they're all public servants. So those 9 will be heavily influenced by the local politics of their state or territory governments. It's really important that, as I say, as many submissions come in as possible to convince all the members of that committee that actually they've got to take this seriously and focus just on the science and the data and not what they perceive to be the local politics. Then in September, the TGA put out what's called an interim decision, where they give an interim finding, either to approve or not approve the rescheduling. That then leads to a second round of public submissions, and then a final decision by the delegate, which is published in November. And then if these substances are to be rescheduled, they're rescheduled, the rescheduling becomes effective from the following February, so February 2023. Now, it is a lengthy process, but what I would say to all of you on this call, if you like what you're hearing about psychedelic assisted therapies, and clearly a good many of you know quite a lot about these medicines, please make submissions and put into those submissions as much effort as you can, because your voice is important. You know, last time around we had about 600 submissions, which were 96% in favour, 2% qualified in favour, 2% against. This time around we want at least 6,000 submissions to really show that this is becoming an important issue in the community. So, Gavin, if we can just make sure that we circulate to everybody the various links, and particularly the how-to guide as soon as it's finalised.
Yeah, absolutely, we can. And that's a great description, and it's nice to see, I guess, some of our longer-term, what's it called? You know, followers, like Kayla has said. It's great to hear the position evolving, and you know, I think really the crux of it is that we're not coming into this with any, you know, delusions of what it is. But I think it's relatively clear at this point that you know, Australians have a right to you know, get access to these treatments when in need. So, all right, guys. Well, we are 10 minutes past the hour. We went a little bit longer than we thought, but it was some really interesting conversation. We did have Nigel has unfortunately had to leave because he has to take care of his partner who's not well. Are you still there, Nigel? Oh yeah. But we've got obviously some amazing talent here. Would people just like to ask some questions? We can sort of fill the rest of the space with that. And also, Trail, maybe worth mentioning, you did talk about the CPAT program. If you're a clinician on the call and you're interested in training as a psychedelic assisted therapist, maybe we can speak to some steps people can take there.
Sure. Yeah, that sounds like a good idea. Yeah, I mean, we'd love to have you if you're interested in working in this clinical space. The CPAT program is really fantastic. It's been a real pleasure to be involved. You know, when Peter and Tanya first approached me to be involved in Nigel, you know, it was something that I really saw as a great opportunity to further the field and the profession. And, you know, I've just had so many wonderful experiences meeting psychiatrists, psychologists, psychotherapists, counsellors, all of whom, you know, want to make the world a little bit different, a little bit better. And so, you know, if you're interested in this work, you know, we need you. So come along, jump on board. We'd love to have you. Yeah,
well, we need you is probably the crux of the situation, because the TGA has also told us. I mean, someone made that point. You know, okay, well, cool. If these get rescheduled, what then? Who's actually developing the, you know, who's actually providing the treatment? And it is, you know, they've requested that we have clinicians trained through that CPAT program, which is, you know, as Peter alluded to, based on really the best training out there, and is regarded as the best training of its kind in the world by the Imperial College of London. So that's a really, really great achievement that Trail and Nigel are very humble in taking credit for, but it's a really, really impressive thing. So, all right, we've got 2 hands up. We've got Sandy. I'll ask you to unmute and you can ask your question.
Hi there. Hi, everyone. Look, I very much apologise. I actually had a bit of a mind blank. It's been a very crazy day, and I got on the call late, so I apologise. I haven't heard most of it. But I'm just really grateful to be here and to see that it's a live gig. Look, I'm actually writing a book about healing trauma and PTSD, and also working with non-ordinary experiences. And I'd really like to connect with anybody here that there could be a synergy, because yeah, I'm just exploring a lot of different things in my book. yeah, so yeah, really much the non-ordinary experiences, and it's based on my own lived experience, and sort of looking at this space where I feel that there's also a connection with this sort of medicine and healing. I've had my own psychosis experience, and from what I can gather, I don't know if I would actually qualify for some of these treatments because I've got bipolar 1, even though I'm off medication. Yeah, but anyway, I don't mind, but I'm really, interested to connect with anyone that feels like they'd like to connect with me.
That's awesome, Sandy. Well, we do have this amazing community of a chapters group, which is maybe a really good place for you to connect with some like-minded individuals. And Scott, who is here, who's also a chapters manager, he's behind the scenes. He can put a link in there, and you can join. That could be a really great way for you to get some of those experiences and discussions with like-minded people. So thank you very much, Sandy.
Another thing I might just say, Gavin, is that if you go onto our website and you go under the shop, I think it's the shop tag, you'll see a book about healing experiences, which may be quite helpful to you as you start thinking through the shape of your own book.
Yeah, definitely. And so there's the chapter there. Thank you, Scott. Okay, thank you.
All right, you're welcome. Thanks, Sandy.
Is there a cost to join the group, or how's that work?
It's completely free. Completely free.
Awesome.
Yep.
Love it. Thank you very much.
You're very welcome. All right, and we've got a handful of other questions, and I'll get to Barbara. Tiana is asking, do you have any work, education, experience opportunities for psychology students? Probably worth just sending an email to cpat@mindmedicineaustralia.com, and we can figure something out for you there. And Andy's asking, Trail, what level of qualification is required before registering for the course? That's all on the website. Maybe you can check it out there. Is that the best way to do it, Trail?
Yeah, sure. I mean, just to say in brief, it's, we're a broad church, so it's not designed to be too exclusionary. What we're looking for is people who meet some kind of clinical standard, whether that be, a psychiatrist down to a counsellor or a psychotherapist or an OT or a chiropractor or something like that. It's someone who's got professional registration in the space, and there's a number of different options that we create within the CPAT training. So we also do take students in those fields as well.
Awesome. Thanks for explaining. All right.
That if you're a student, it doesn't mean that you could be a lead therapist. You have to continue your training and qualifications and certification.
Cool. Great. All right. Finnegan, SD, I've seen you active in the chat, so I'll ask you to unmute and ask your questions and feedback.
Hi there. Can you hear me properly?
Yep.
Yeah.
Beautiful. Actually, my original question was about, I'm a student at the moment and how to get involved, etc. Not necessarily in the CPAT, but just in the volunteering, etc. But it's one of those questions which it is just on the website, and I have looked myself, but I was going to keep it simple. But no, I guess I have a bit of a further on question. I'm still in my first year of university, so I'm very far away from clinical registration. And I always I've had my finger on the pulse of the research, etc. for, say, almost 8-9 years since I got back from South America and had my own experiences over there and saw the help that it can be achieved. I guess kind of a bit of a far in the future question, which is where I'll be when I get registered. Do you guys ever see a world where these therapies are conducted in group settings and more informally than the therapeutic stuff at the moment? I know this is where we start, it has to go step by step, but do you see a world where that happens?
Well, I mean, the group thing is definitely happening. We have a healthy persons trial running this year, which will take a group format. John Hopkins do some of their work in group format. So the group therapeutic part is well on the way, and it is kind of happening, and research is being conducted into that. I think your question though, Finnegan, is a kind of moves a bit beyond that, which is, are you kind of asking, is there a way or a space that these medicines could essentially supplant the utility of religiosity or the church or any of these other functions, which is kind of broken down? That is there a space in where, in ordinary human life, these practices could be used as part of, actualizing the human transcendent function? I mean, maybe that's possible, but I would suggest that that's pretty problematic in a lot of ways. And least of which is that these medicines, even in traditional cultures where they're used very widely, are still held by a select number of people. There are still essentially caretakers of these medicines or these substances. They're very powerful. And so the question becomes, who are the caretakers? Who decides who the caretakers are? All those kinds of things. Now, that then starts to cross away from our kind of area of providence, which is, to talk about, the clinical application, and starts to deal more with, what an organisation like the Australian Psychedelic Society is probably focused on.
Right. I mean, sorry, not to cut you off. I think that's a really great insight and kind of had me thinking, was I asking that question? And it might have been my phrasing. What I'm really getting at is what I'm imagining, what I would hope for in the future is that obviously I had my experiences, which I'm not trying to kind of, like you were saying before, which I clicked with amazingly, like extract that and, create some kind of religious thing or replace something or bring it back for what we've lost. But more that I think it's important to have trained professionals conducting this stuff and as a safeguard, especially in our Western society. But more so that, a lot of these medicines kind of help people find their own answers, just like therapy does.
Oh, yeah.
And how I imagine it is in a natural setting. That's my main big thing is like, at the moment it's rooms, et cetera, and stuff like that. But I'm picturing, because I love the idea of like nature therapy as well. And I think obviously combined can be amazing, but.
Yeah, well, I've worked a lot in kind of the wilderness therapy and eco psychology and things like that. So I take your point. And obviously the setting makes a big difference, and difference between doing medicine in the daytime versus the nighttime, doing inside versus outside. These all make a difference because they affect the setting. I can't honestly, within a medicalized mandated space, see a way that could happen, given the need for safety and control as the first step. So I think that's probably unlikely.
Cool.
And that's the point, if I can say, as a first step, we're really focused on medical environment, properly structured, the sort of therapy that Trail is talking about. But the reality is, you can go to Holland and you can go to a retreat where you've got people in attendance who know what they're doing, and you can go there as a healthy person without any permissions from government. Yeah. And yet when you walk the streets of Amsterdam, it's a civilized country, it's operating really efficiently. And the fact that psychedelic therapy is available to anybody hasn't in any way endangered people. So you sort of ask yourself, well, why can't Australia follow that model? I think my answer would be it's just too early. We're a conservative country. And I think our first point of call has to be people who are suffering mentally, who could benefit from these therapies, and not to get too much ahead of ourselves.
Yeah, no, it's very wise. And so, just conscious Barbara's been waiting there as well. But sorry, Barbara, go for it.
That's okay. I was just wondering, when we finished the last session of the fundamentals of psychedelic assisted therapy, there was a waive the fee for the CPAT course. And I was just wondering, if we signed up for the course, did we have to actually take the next one that was coming up, or could we take one next year?
No, I think, well, I'll actually check. I'll check with with the guys about when that one is available too. But it should be fine. I don't think we have any courses scheduled for next year at this point. Actually, we'll Trail, you're here. Maybe you can make the call now.
Of course.
Yeah. All right. No, totally fine. Yeah, we can do the next one. Although we would, if you can make it to this next cohort in July, that would be amazing as well. All right, guys.
Does it when you're doing the course, because I'll be finishing in, I think, like August with the course I'm doing now. It's not a course, it's the thing I'm doing now. Does it take a lot of time? Like, is it a full-time sort of course where you're going to be doing, 30 or 40 hours of study a week?
No, it's not 30 or 40 hours a week. It's designed for professionals. But it is a serious undertaking. It's not.
I understand that. I just want to know how much, time I'm looking at.
Well, I mean, I think the answer to that is how long's a piece of string. I mean, some of our students spend, a few hours, and some of our students spend, 10 to 15 hours, so it depends on levels of knowledge, experience, all those kinds of things.
I'm that 10 to 15 hour student.
That's a week though, he's talking about.
Yeah. Okay, now I was just wondering if we had to do it, if we signed up for the course, which I will, if we had to do it sort of immediately, or could we do it sort of?
Yeah, you can do it later.
Yeah. Because I feel like the course, because MMR is so new, I did not realize it was this new. I thought had been around for a couple of years actually. I feel like the course will also get better or evolve, as someone said on here.
Yeah, of course, no doubt it'll evolve.
Yeah. Okay, that was all.
Thanks.
Awesome.
Thank you.
All right. Steve, did you want to ask a question as well? And there's some interest. Oh, yeah, go for it, Steve.
A question for Trail. I've just been starting to read this book, Psychedelics and Psychotherapy, which has an intro by Gabor. I think it's from Vermont, which I think must be Canada.
Yeah.
And just started reading into that. And I get a feeling that the psychedelic assisted therapy is starting to sort of get bigger and bigger, and all sorts of things going on. And one of the things I was reading there is a lot of people are proposing psychedelic assisted therapy where the people who are sitting are actually also on the psychedelic trip at the same time as the person, to get into the zone with the person whilst they're doing that. And I kind of have mixed thoughts about that, and I guess you guys have run up against it, and I was wondering what you were thinking.
Well, I guess my view on that is that would probably be unnecessary, number one, and two, risky and probably a mistake. But it is important, I think, for the therapist to have a pretty strong ability to navigate altered state. When you work in that space and you're accustomed to it, it's actually unnecessary for you to do that, because of the level of attunement. You'll experience what sometimes referred to as a contact high anyway. So your state will be dramatically altered through the attuning process. So I think it would be a mistake to set up those conditions for a number of reasons. Obviously, one is the risk. You don't want to be incapacitating kind of executive function in someone who's got responsible for another person's well-being. But number two, I think it also creates a setting where much of the subtle skill that's required to navigate the space is actually lost, because people are just going to take a dose of the medicine. And I've been doing this work in altered states and ethnomedicine for a long time. And if you think about in traditional shamanic cultures, the shaman ingests medicine in order to learn how to navigate the worlds. But eventually the idea is that they can do that without the medicine, that the highest form of practice is to be able to do that at will, by choice, without any kind of inductive process other than one's intention. And so that, I think, is something we should keep a pretty close eye on.
Kind of validating what I was thinking. I was starting to wonder, am I falling behind the loop? But I was sort of thinking that, for me, yes, I think it's important that people have had those experiences themselves. But in terms of sitting with someone, I think it would be really important to have someone who's kind of integrated, their left-right brain integrated. So they can be zooming in and out of focus. You can be zooming in where that person is at, but also zooming back from a bigger picture to look at a bigger picture of what's going on. So yes, I'd agree with what you're saying. So thanks for that.
Thank you. Finnegan's just made a point here that in some traditional cultures, it's the shaman who ingests the medicine, not the patient. I would say, if you were to take a survey of that around the world, I would say that that's more common than uncommon. The shaman is the person who journeys on behalf of, we'll call them the patient. And so there's lots of things there.
Amazing.
The whole world rabbit hole.
Yeah.
Yeah, well, I mean, look, you know, if you're interested in this stuff and learning from the wisdom of, you know, Nigel and Trail, I, you know, strongly recommend joining the CPAT program. We have truly phenomenal feedback from it. And, you know, it's just really a wonderful experience that people have. Let's see, what have we got here as well? Rachel said, sorry for attending late. I have so many clients who would benefit from this therapy and hope that I can access your course information later. All right, well, look, we've only got a few minutes left. And so one of the things we wanted to talk about here is kind of like Peter said, we're not just here to raise awareness, that's what we do, but we're actually here to really change things, to actually change, you know, the accessibility of these medicines. So I'll just bring up a slide, which just shows how you can actually help and where we're at now. Where are we? If I stop share, sorry for 1 sec, guys. I'll just bring that up. Yeah. All right. So, so yeah, basically over the next 26 odd days or so, there'll be a yeah, we'll be you know, the TJ has got their public submissions process opened, and Peter, do you want to speak to how to?
I do, but your slides keep changing.
Oh yeah, sorry, mate. Yep.
Yeah, just we've had 50 years of prejudice and bias against these substances. The reason they were outlawed as part of the war on drugs had nothing to do with science and data as it applied to medicine. It was all about attacking the anti-war movement in America. The net result today is that there are a number of so-called experts who have labels of expertise, but still suffer from the bias and the prejudice associated with these substances. So the first point I just want to make is don't assume that every expert you hear from is giving objective views. Look at the science and the data yourself. Go to the trial results. That's the best source of information. Second point we're making here is you can see our submissions and our explanatory memorandum online through our website. Go to the TGA, go to the news tab and then the TGA tab. We're an open source organization, so everything we do in terms of submissions to regulators goes straight onto our website, so you can view it. If you would like to make a submission, and I'm really hoping that you will do, because we need as much support as possible to show that there's widespread support for rescheduling. Look at our How to Submission guide, which will go onto our website tomorrow. And we'll put links to all of this when we circulate information to you after this call. And you know, again, this is a historical time. After 50 years, we have the chance to create change. We have the chance to reach out to people who are suffering terribly with mental illness, where the current system's not working for them, and generate a change which will give them hope and a real opportunity to go into remission. And as Trail's quite rightly said, this isn't going to work with everybody, but the data coming in from overseas does say that the treatment effectiveness is remarkably high. It won't put everyone into remission, but it will offer the opportunity of a treatment that can work with a large number of people who aren't helped by the current system. So, you know, please look at our website, and if you want to see this happen, don't leave it to other people. Get involved, write a submission, or 2 submissions, one for MDMA, one for psilocybin, and be part of this. And boy, isn't it going to be an amazing feeling if this rescheduling happens and the medical system has an additional tool to help people suffering from mental illness. And we see many more people leaving the mental health system, not in desperation, but because they've got into remission. So please be part of this.
Amazing. All right. Well, strong words there. And with that, we're bang on 90 minutes. So we'll send out all that information for you guys. But yeah, I think Peter really summed it up in a very inspirational way. This is an actual opportunity for change, not just to sort of talk about these things or read them, but for actual change here in Australia. So we'll send you all that information. And what we'd love as well is not just for you to make submissions, but for you to galvanize support and help us really get those numbers up for the people that you know in your circles that obviously aren't on this webinar, and for the clinicians out there who have patients that you feel would be benefit from this, like someone commented. Would love you to really rally everyone to to put democracy to work and demonstrate that this is something that that people really want. Sorry, Sandy, do you have something you wanted to add there? Yeah.
Just very quickly, I'm just wondering, I think it's really great. I've come in late, but I think it's really great to have this meeting, and maybe even if it's possible to maybe run a webinar on how to do this submission, because it's great that you're asking us to call to arms. And I'm also wondering if you've connected with the Greens Party, because I know that they're into different sorts of open to different ideas. That's just my comments. Yeah.
Yeah, I mean, the Greens Party have been very supportive, and they've spoken in Parliament about these therapies. But it's a good suggestion, because I think they're a party that could well send around information to their members and encourage
definitely
to write submissions.
Like you want why not go for 60,000?
Hey, I like the sentiment, Gavin. The pressure's on.
Oh, absolutely.
Well, if you've only got like May, and you can look at all your centres of influence. So go the Green Party and everyone else, and with all the election stuff going on, people are really excited about anything that's really about change and innovation. So we're going to have a housing revolution. Why not have a psychedelic revolution?
All right, Gavin, we're going to organise a how-to webinar.
Yes.
Where we go through the submission process.
Absolutely.
That's really worthwhile. Thank you.
Great idea. Great suggestion.
Awesome.
All right, guys. Well, lots of really wonderful feedback there. You're all welcome. Thank you for showing up. Yeah, let's get this done together, eh?
All right.
Pamela's asking, do we have to be a therapist to put in a submission? No, there's 4 categories. You can be consumer, patient, researcher, general interest, or clinician, and there, everything counts. All right.
Right.
Awesome, guys.
Bye.
I'll speak soon.
Bye.